All right, Bismillahirrahmanirrahim. All right, so now time is now 3:22. We'll get started for our last and final session for the conference, inshallah. Once again, congratulations to Dr. Farah for winning the poster presentation, and congratulations to everyone else for participating. It's amazing to see more and more peer-reviewed academia coming out from our ranks and helping with the the connection between our faith and mental health. So mashallah, congratulations to everyone who participated and who read the presentations and witnessed them. So thanks for staying with us till the last. We saved the best for last, I would say. Our last topic, our topic for this session is spiritually and culturally adaptive strategies to address behavioral addictions with Dr. Ahmed Hassan and Abdul Aziz Syed. So just a few quick announcements, just housekeeping items. So again, I'm going to be the moderator for the session. I work as a family physician, so I do a mix of mental health as well as other general practice things, and I've also done a little bit of some research in the mental health area because as a family physician, we see it so often in our practice. So definitely that's kind of my interest in mental health myself. So it's fascinating to see all the different presentations being taken place at this conference to help with a lot of these different areas. And in terms of, if you have any questions for the speakers throughout the presentation, please feel free to share it in the Q&A section, and we'll discuss those towards the end of the presentation around 4:20 or so. And we will send you links through Google form survey for your feedback. We do appreciate that you fill them out and give us your honest feedback to help make them better for next year and ongoing. And all the sessions for today, as you may know, are accredited. So you'll also get a form for those to fill out to make sure that you get your accreditation. So please stay tuned for that. And please feel free to share any benefits that you might have learned from the conference through social media, Instagram, Facebook, Twitter, with the hashtag CNMHC 2021, just to help us raise more awareness and share knowledge about the conference within our community. So with those housekeeping items out of the way, I'll move into directly into the session. So the objectives of the session, very briefly, the four main things. I'm sure, inshallah, we're going to learn a lot of other interesting things as well. But number one is to describe the psychosocial and spiritual model of behavioral addictions, including how this evolves over the developmental lifespan. Outline a culturally and spiritually sensitive approach to assessing behavioral addictions and associated comorbidities in Muslim identifying patients. Thirdly, to apply motivational interviewing skills and harm reduction strategies that incorporate spiritual considerations. And fourthly, to identify resources for Muslim identifying patients with behavioral addictions. And this session will also include some case scenarios and embedded self-reflection questions to help link the content we'll learn today to real life practice. So just going to quickly introduce our two speakers that we're honored to have with us today. First is Abdul Aziz Syed, who's a licensed clinical social worker and certified sex addiction therapist, and currently works as a therapist with the Khalil Center. His career has been focused on working with Muslim clients struggling with a variety of life stressors, including behavioral addictions and mental illnesses. He believes strongly that every client is an expert on their own experience, and that by creating a safe, welcoming, and warm environment, people can begin their journey towards healing. When therapeutically beneficial, he incorporates the Islamic tradition and principles as well into his practice. And secondly, our second speaker is Dr. Ahmed Hassan, who's an addiction psychiatrist and a clinician scientist at the Center for Addiction and Mental Health. He's also an assistant professor in the Department of Psychiatry and the Department of Pharmacology and Toxicology at the University of Toronto. He completed his psychiatry residency, mood and anxiety fellowship, and addiction fellowship also at the University of Toronto. He's a fellow of the Royal College of Physicians and Surgeons of Canada and a diplomat of the American Board of Psychiatry and Neurology. He completed a master's in public health from Johns Hopkins and has a particular research interest in the biopsychosocial and spiritual aspect of addictions. specifically improving the care for patients with concurrent disorders, with a focus on patients with both substance use disorder and stress-related disorders, including trauma and post-traumatic stress disorder. So with that out of the way, I'd like to begin the session. Inshallah, either Dr. Hassan or Abdul Aziz, whichever of you would like to go first. Maybe Brother Abdul Aziz, if you'd like to start us off.
Inshallah, Dr. Hassan will be starting with Dr.
Okay.
Hassan. I'll share the slides and I'll go through. Okay.
Perfect. Sounds good. You're
welcome.
Okay. Thank you very much, Dr. Sulaiman. This is thank you for the nice introduction and getting through this. Okay, so maybe one of the housekeeping. So who's going to be moving the slides? Someone else.
I can do it.
All right. So you're doing it. Okay. All right. Okay. So we got the introduction out of the way, and we're really pleased to talk to you today. And thank you for staying at the last session in the conference. So hopefully, hopefully, you saved some energy for this one. And we'll try to keep it brief, but also beneficial for you. So our understanding is that most of the the audience really it's for this sessions, the audience were meant it to be mental health provider. But if you're not a mental health provider, this definitely can still be beneficial. But we kind of tier the text with this language. So just keeping this in mind. Okay, so let's go to the next slide, please. I think Dr. Sulaiman went through the objectives, so I'm not going to go through it again. But I really want you to keep in mind that like here it says a lot about behavior addiction. It's definitely can be applicable even in non-behavior addiction. If you want to apply it for substances, it definitely can apply to others as well in the model. So just keep in mind, because we're going to talk about general stuff, but we also going to zoom in a little bit into some of the behavior addiction pieces that might be applicable, so we can make the some of the cases more vivid and more applicable to what we are going to talk about. Okay. All right, we have nothing to disclose, so that's good. All right. So Sheikh Abdul Aziz have been very kindly to present a case of his. It is I think it's a real case from his practice. He sees this almost on a daily basis. So it's a young male. We didn't really identify any male, but any names, but we'll keep this case in mind. That was referred to you by another clinician for excessive porn use paired with masturbation. The client reported masturbation several times a week and wants to stop, but unable to. He reports that he has used going back to a young age, and growing up in his household, he felt like a cage. Client report being forced to attend religious memorization like Hifz sessions on school, where he was bullied also. So if you're already dealing with a lot of behavior addiction or even with substance use, this case is not going to be very odd. It's going to be very familiar. We want you to have, think about the initial presentation, the initial impression of this case. In mind, would you consider, I want you to keep, because this is what we're going to try to answer in this session. Would you consider this as a clinical problem? And why is it only porn? So we didn't mention here, but maybe it's only porn, but there's no other substance. So why was it only porn that he started with? Keep that in mind. How would you incorporate spiritual value into the assessment, if any? Would you consider incorporating spiritual value? And do you feel comfortable with that? So remember that as we go along, we will try to refer to it every time as much as we can remember. Okay. All right. So general definition. So addiction really is derived from a Latin word that means like bound to or enslaved to. It's very intuitive to think about it. The ASAM, which is the American Society of Addiction Medicine, defined it as a chronic disease of the brain's motivation, memory, and related circuit. An easy way to even remember it, it's a chronic brain disease that consists of a lot of relapse. That's another way of defining it. Okay. Thank you. Next session, please. Next slide. So addiction is a long-term disease of the brain. I know this is a busy slide, but in general, we wanna tell you that there is several dysfunction in multiple areas of the brain. We're gonna touch on it in the next few slides. The dysfunction is biological, psychological, and social, and can have a spiritual manifestation for sure. It might start off with a reward or a relief. So that high could be a high or a relief. But with repeated use, it will lead to several psychological and physical dependence, and this get triggered across the lifespan. So how it started is not what will contribute to it later. So something that started it, but something get better, psychological or social, but others will trigger it. And I know this is what I'm saying is a bit vague, but I'll explain it as we go along. Now, like any other chronic disease, as I said, it has a lot of wax and waning, improvement and decline. So you have to keep that in mind. Exactly like other chronic diseases, if we're considered pure medical, like diabetes. And also, just like any other chronic disease, it requires long-term treatment that needed to be done. Next slide, please. All right. Okay, so this is just to get your way around it. So in addiction in general, there is substance related and there is non-substance related. The one on the left are excessively well, I wouldn't say excessively, but it started to have more research into it, which is like the gambling, the gaming, the sexual, emailing, and also there's other part of the exercise and eating and tanning. Now, when you this is just for you to get in general like how we categorize it in the DSM and maybe in the research, but it does not obviously mean that if a person is in one category, he cannot or she cannot be in another category. They definitely can be very interrelated and actually more commonly so. Next slide, please. All right. Okay, so we'll talk a little bit about the substance and the behavior in general. Both of them can affect the brain in a similar way. We'll talk about the dopamine pathway. So they both has affecting in the chemical level. They both had an effect even in the third point, which is a neuroimaging level. So even when we do our PET scan and MRI scans, we found very similar pathways between the brain, like between the brain of individual with, let's say, gambling, or an individual with alcohol use disorder. They will obviously both lead to addictive disorder, which is have almost similar criteria. And this is changing the same criteria, which is can be loss of control, which can be categorized as craving or using more in time. And the same thing applicable for substance and behavior. They both obviously can lead to a negative and emotional reaction. Okay, so if we're speaking also about the spiritual piece of it, just to let you know, even this has been recognized in Islam that both have shared. At least 3 verses in the Quran have mentioned both of them, which is the khamr al-maisir, one of the major substances, the alcohol, and one of the major behavior addiction, which is gambling, together, even sharing their effect, their negative effect, or what do they have in common. So even Islam recognized how commonly related these 2 different behaviors or behavior and substance together. Okay, next slide, please. All right, okay, so we'll break our session into questions, which to make it hopefully easily to follow. So the first thing is how does it develop? How does a behavior, specifically addiction, develop? And it can be applicable to a substance. And it really varies from individual into another, and then several factors can be taken account. I think we put trauma is a huge one, but there is several other ways. And let me take you to the next slide. And the next slide, this is just one way of explaining. This definitely is not a comprehensive way, but we thought that the visual of it is very nicely done. It can start by the right upper corner here. If you have a family environment, dysfunction in the family environment that interact with another cumulative trauma, we call it. It could be an early trauma, whether it's an emotional, sexual, or even physical abuse, and then it will lead to other trauma factors, and basically that's combined something called a catalytic environment, which can contribute to the development of the bigger problem, sexual addiction, which can also evolve into abnormal sexual behavior, and then it leads to a whole vicious cycle. It doesn't mean that everybody here has a family problem or a trauma history, but this is a nice way to think how this is all can interact. This is definitely an interaction between the biological, psychological, social, and also the spiritual part, which we're going to talk about it today. All right, next slide, please. All right, okay, so biologically speaking, so most of the thing that happens in our brain, especially when we talk about, like, you saw the definition earlier for the ASAM is about the reward. So the reward comes from something called the dopamine pathway. And this is where the problem, you can see here, there's something called in the picture in the brain, the VTA, which is the ventral tegmental area, where the dopamine can be really projected from this area into the other area, nucleus accumbens. This is just a pathway of what happens in our brain when we get rewarded, a high level of dopamine. Eventually, when this gets triggered often, and this has become very, very rewarding, other pleasurable activities, such as eating or enjoying social activities or anything else that used to be bring us pleasure in the past, is not bringing in pleasure anymore, because the reward from that new developed substance is pretty high. And then the biologically speaking, after a while, after getting used to that enjoyment also will start to decrease. I call it personally as anti-addiction mechanism or behavior, where the sensitivity of these cells for the substance of the behavior that introduce become less. So that means that it's not bringing the first enjoyment that the person had, or the biggest relief that the person had, which means behaviorally that the person will need to take more enable just to keep up with feeling normal again. So this is in general what it means, but also it's important to say that it does not mean that necessarily biologically treatment will get to do with the dopamine, because yeah, it started with the dopamine, but it activates other cells, norepinephrine, serotonin. So the treatment might be very, very, very different than focusing on the dopamine. Okay, next slide. All right, okay, I'll try to simplify to make this clear. This is actually happening in every day-to-day task. So if you eat a tasty burger, right now it's like, I hope it's lunchtime or something, and you eat tasty burger, you're hungry and you eat tasty burger, the dopamine will get secreted. The picture of the brain here, remember, just the dopamine when it gets secreted, the brain trying to capture what exactly happened during that moment so it can be repeated again. It will memorize how feeling you were before. Maybe you're super hungry, maybe you're super happy, who you with, what was the sound. Anyhow, should try to capture as much as data as possible in order for us to that repeated. So if you enjoyed that tasty burger after that, you're gonna go again and try to take that burger and obviously lead more. Okay, next slide. So what happened in actual behavior, problematic behavior, such as excessive gambling, or it could be substances like the nicotine here, or again going to the gambling or the playing. So you can see the difference between in this slide, between the slide before, I kind of bolded and increased the font of the dopamine reward. Obviously the dopamine can be secreted, the reward going to be secreted is way much higher than when you eat a burger. So the amount is really, really, really high, which will lead to high reward, high probability of engaging into that behavior. But an important question you could ask yourself, so maybe a lot of us have tried PS5, I think that's PlayStation 5, but still didn't get addicted to it. A lot of people have smoked once or twice in their life, but it wasn't a problem. Maybe some actually engage in gambling behavior, but it's not a problem. So, which brings us to the next question on the next slide as well. So why would some people develop this behavior addiction and some not, even after both of them get exposed to it? So it has to do really with biopsychosocial and spiritual. Biologically, so there's something called epigenetic, where epigenetic means on top of the genetics, means if my parents never smoked, for example, and I start smoking, I influence my genetic, which makes my offspring, if they try the same substances, for example, a cigarette, they will like it more than an individual who also tried the cigarette, but their family never tried it. So how much that dopamine gets secreted, it can be influenced by the genetic. And that's why family history of substance or family history of that makes a big difference. Okay. Psychosocial, this is a more intuitive thing that we can all understand and keep it in mind. Obviously, everybody like the grow up environment is different. We heard our earlier case about how he felt that his family, or I think the phrase is how he felt that he growing up in a cage. So obviously there may be a lot of restrictions. So there might be some way of like he might have found the porn or the masturbation as a way of distracting from the problem, or a way of or maybe a way of to be applicable to that case. Maybe Abdul Aziz can talk more about this, but because he knows that the person may be applicable, that he felt that it's a way of control. Okay, my family is controlling everything on me. That's the one I have in control of it. That brings the dopamine high. I indulge more into it. It brings that relief from the cage, that sense of control. The one you can see actually in red balls is like actually this is for the references bottom from the research, that what evidence basis tells us in terms of, and very specific to behavioral addictions, the main common reasons why people indulge into behavior addiction more: distract from problems, escape from reality, avoid loneliness, and avoid annoying duty. So you can see if that person already have a problem with this and then found this behavior that helped with this, so the dopamine increases or get a relief from whatever negative feelings that they, of course he will engage more, and that will be the case. Okay, and then the spiritual piece. I want to so I want to stay a little bit about this point. In my opinion, this is the most important line in my part of session. It's just because like you might be exposed to tens and tens of lectures and workshop and sessions that talk about biopsychosocial, but very few conference or talk will talk about the spiritual piece. And I hope I really explained it right. I don't have any visual slide, but maybe this is something I will think about it to put it more for future presentation. Anyhow, every individual has a mind, body, and spirit. The spirit in Islam, it views in the Quran that Allah created the spirit, God created the spirit, and then as in one of the surah Al-Shams, he created that soul, but he also showed it a good and bad. So that also indicates how every single spirit will be exposed regardless of any bad influence, if you want to call it bad. And that could be either an exposure to it or just knowing about it. Abdul Aziz will have a very nice slide at the end, I think it's number 28, where it talks about like how the spiritual progress. It begins with fitra, and then it can be very complicated in the beginning, but I'll try to explain it and simplify it in there, because this has to do with this. So it begins with fitra. The Prophet ﷺ has said everybody will be born with fitra in his good heart, but then there is rituals, there are Islamic rituals or religious rituals that combine with knowledge. So the knowledge could be coming from culture knowledge, or a support. We heard a very good story from Sheikh Hilal earlier on about how to support and change actually behavior of addiction. So knowledge about how things, it could come from the environment, it could come from family. So anyhow, so with the continuous of the rituals and continuing of the knowledge, the person would reach until the end. This is like usually the highest, a connection of the spirituality. I think it's called here sound heart, where you have a very good connection spiritually with it. This is where you bring the reason for why you're doing this behavior. It brings your joy, your compassionate, your love. And this as beautiful as it sounds, it really varies from individual into another, and where it occurs very varies from individual into another. So I'll give you an example just to explain that. The reason why I'm praying right now is very different than why I was praying 10 years ago than 20 years ago. It varies from a person could be doing something because it is involved in a ritual because of the culture, but the meaning, and then as the knowledge increases, as the awareness increases, and then the experience happen and the connection happen, then the reason completely shifts. So why am I leading with all of this? Because it also it matters of how the spiritual protect or can lead to certain behavior versus others. Meaning, as we already saw that, like, I'm doing a lot of research, and then religiously is a very well-known factor that protects from a lot of behavioral addiction, but also a lot of substance addiction. And this is can be very well found. Like if you look into research in the Muslim countries, you'll find in some substances the prevalence is very low. We actually are in the process right now of publishing another paper that showed that even the prevalence of substances of American Muslims is pretty low to this. So there is something that had to do with the spiritual. If you want to call it culture, but it has to do something with the spirit. The knowing, so when you know what the meaning of that spirit, what make that person go for one behavior. So for example, our young case, why would he choose only porn? Why was he not before? I already heard one individual talking about, like, when he was using the porn, that was for him. He felt that this is the most acceptable thing for him. Like, I was not hurting anybody. I'm just watching films. They already give the consent. I'm not doing any I'm not hurting anybody. But alcohol was no. It's a big thing. It's a big, because it's very clearly said in the harm. So it depends on the individual. This if the spirit is seeking something high to look for pleasure or seeking a relief, it will find a way what is acceptable. And that's what I mean, what is the personal meaning. So it will find its way. So that would, for that individual in that time when he was exposed, that was acceptable. Porn for me is acceptable. Okay, I got this porn and I was not hurting anybody. But then the person growing into life and then noticing that it's becoming a problem. Maybe it's causing a lot of things. And then what the biggest problem is if also the spirituality grows. The spiritual good grows, even there's also some, maybe if you want to consider it bad behavior. And this is where the spiritual pain happens. And it's actually very nicely mentioned in the session before me. There's a conflict here. Oh, maybe I'm a hypocrite. Why am I doing this? Because it's conflicting with my spirit. I'm supposed to do all these good stuff, but I'm not able to connect. I'm not able to find halawat al-iman. I'm not finding this pleasure of the iman. It's preventing me. And this is where what we call, and I heard it also in the session in the morning or the afternoon, early afternoon, it's called in something dialectical. It's like a conflict. And this is where the patient usually are very much in distress. It can help, it can trigger him to seek treatment, but it could also play as a stigma file. So in summary, that you got to understand what is the meaning, what was the meaning of that? Why was it, how much of is it taboo to that individual back then, and how much it developed and changed over time? Because the meaning of it could completely mean absolutely very different when he was a teenager, but as an adult, he developed this connection and he felt that it's interrupted. Treatment-wise, actually, I think Dr. Zainab has mentioned this, the dialectical, this opposing can actually works very nicely in treatment. We can, because again, the same Islamic resources, the ayah that I mentioned, that means everybody has a good or bad. So it doesn't mean, but it's just the difference in Islam is we have to always seek that strong and the positiveness to overcome the negatives. So hopefully I explained a lot, but that just give you an idea of how does it spiritual develop, because the meaning of it, depending on that lifespan of the individual, could vary from one individual to another. Okay, all right, next slide. All right, I know this is a complicated diagram here, but and almost every arrow has a bidirection, but it just tells you that it's very much interrelated. So I know an individual who always has a problem with seeking prostitute or seeking sexual behavior, but only when he drinks. Okay, so when he drinks, so that is not a problem to him, but when alcohol comes in the way, it almost always combines with that. So it just tells you of how this can, the substance use can lead to behavioral addictions, and then maybe the behavioral addiction can lead to all these problems that you can see at the bottom, which is basically the consequences, which lead to a depression and anxiety, and then influence. But it could start also the other way around. Maybe we can see a depression, anxiety, or a PTSD, a trauma, that lead to a substance use, then they lead to behavior addiction. So it could vary, and every individual is different, but it really need to be assessed on an individual basis. Next slide, please. All right, I'm not going to talk about this a lot. It's just more or less of what we talked about earlier. Any psychological distress will point out that there is attachment problems, and then this addictive will become self-soothes, like we saw in the case earlier. I talked about the psychological as well. What make it acceptable versus not? This is where the spiritual, in my opinion, comes part. This is why I think it's summary for all of that. Next session, please. Oh, next slide, please. What are the possible consequences? So I think everybody knows that it leads to a lot of problems. It varies. The last two is actually what comes with the substances. It can lead to death if whether by intoxication or by withdrawal, poverty, a lot of problems. So I'm not going to stick into that much. Next slide, please. This is more as if you want to evidence-based, what the literature says specifically about behavior addiction, sedentary lifestyle, lack of social engagement, poor problem with concentration, attention, and increased aggression and violence. Next slide, please. All right. Okay. So now we know it's not good. So why can't they stop forever? Why can't they pull the stocks like they say, and then that's it? That would be it. Or if you're saying to me that, okay, there's spiritual growth and they know about this, so that should overcome it. Well, it's not that easy. This is where it comes to the biopsychosocial for some cases. Okay, so this is a little bit of a pool just to make sure everybody's awake. A person who has been able to stop gambling for several months would have the same brain response when seeing blackjack compared to a person who never gambled. What do you think? Is it true or false? I don't know, should they put it in the chat or maybe?
Oh, people are responding. We got a lot of false, and we got some true question mark.
Yeah. Okay, good. Yeah, I think we've seen agreement, right? Okay, it is false. Yes, absolutely. So it's not the same thing. Next slide, please. All right. Okay, so this is where it comes into the biological piece also take part, but also guided by the psychological piece. So you can see in the top here, I said craving preoccupation stage. So what other stages are there? For any addiction, there's 3 stages. There's an intoxication, or so that could be the substance, or when the person is actively doing the behavior. And then there's a withdrawal. The withdrawal comes from a substance. Everybody know that, almost about, like, it depends on the type of the substance. But also there is a withdrawal comes from the behavior. So I'm doing that. I'm engaging into a lot of sexual behavior, and then I decided to stop. I might get a little bit of discomfort or withdrawal, but you know what? I just realized it's really harmful my spiritual connection or my sound heart. So I push it through and I stopped. And it's been several months right now, and it's everything is stopped. But now once I see, I see something online that really triggered me. Okay, I saw something. The brain connection are not the same. The purple thing, without really very dwelling into a lot of medical terms, that purple thing is the area in the brain that is responsible for the executive function, where it says yes or no. But remember earlier when I say the brain has, when it likes something, it tries to record every single data. So that part of the memory, part of the emotional. Next slide, please. So when you actually, a person who's been heavily dwelled into a behavior and then try to stop and then get triggered by seeing something that reminds them of that pleasure, that part, the part that says no is pretty much overridden by other part, like the memory, the emotion, and the feeling, which just makes it hard to resist. And that's why they always question themselves, like, what's wrong with me? Like, why can't I just stop? You also saw our case in the beginning. He tried to stop, but he can't. He just feel, and that not just pleasure, it could be also the negative. So let's say that case, that make it also more vivid. So that case, he stopped and he engaged into a lot of several months into abstinence. But then let's say he faced his father, who told him that he should do this and that, and he felt again caged. That brain automatically think about the next possible way of control. And this is what, if we scan the brain, usually that's what we get. A lot of like the other emotional and affective that kicking in, making that decision making hard to say no. But it also reflects that in treatment, therapy can actually makes a lot of big difference, because what do we do in therapy? We're actually making that decision making more and more and stronger, more and more stronger. Okay, next slide, please.
Doctor, so real quick, so we're halfway through. So if you could maybe wrap up in 5 minutes.
I will wrap up, no problem. So again, you can see this. So this is all lead to vicious cycles. Next slide. Okay, so how do you assess? Really, the attitude should be like not judgmental, curious, respectful. Culture education is the key. We cannot really explain all about the Islamic culture into one session, but if you're not Muslim and you're treating Muslims, the thing is about more, you learn more and more about it. You can ask questions from the patient or the client, him or herself, but you can also like engage more into a reading. That usually the best way. Very important, as I can see the spirituality really varies from individual to different. Do not assume universality across Muslim values. Everybody is different. However, Muslims' culture norms, like the existential belief about Allah, Prophet Muhammad, وسلم, the family morality exists. This is a common one between Muslims. And I'm saying this because I know like certain therapists, they're brilliant therapists. They might try to connect with their patients in a certain way. They might be jokeful, they might give example, but these are the things that really, you might lose your patient if you start making jokes about stuff like that, or applying example of whatever Prophet Muhammad was doing. So these are the things that are really sacred for Muslims. So this is what I would say is more like cultural norms. So it's better to avoid giving example in these areas. Really emphasize on explaining the process. So every single time I go into, and especially I do this with Muslim, I explain the process from A to Z. This is what we're going to do. You're going to tell me about the problem. I'm going to ask you a few questions about it. And then I'm going to have to make sure your mental well-being. So I'm going to ask you about this, and the depression. And then at the end, I'll talk about management and how ways of helping you. I emphasize on the confidentiality. We just we completed a research project the last few years, and one of the important things is about they're worried about the confidentiality get broken, and if this get into to their employee. So really emphasize that anything you say, don't assume that the participant already know. It's like, especially for Muslims, they have to make sure that this is will kept very confidential. Next slide, please. All right, really follow the normal diagnostic criteria. I get asked about this from colleague a lot. I don't have any DSM for Muslims. It's the same DSM we apply for, but we try to recognize and demonstrate respect for the Islamic individual life. Meaning, for example, like if that person that you saw earlier in the case was indulging into porn once or twice a year, it might seem not like our culturally acceptable, or maybe not that huge, but it's according to that person's spirituality, to what does it mean to you, it could mean a lot huge. And that's actually the same thing that DSM-5. Nothing in the DSM-5 when it's got to do diagnosed with substance or behavior that says anything about the amount of the frequency. So you just it is actually matching, but you just have to keep in consideration what's really the meaning to this. Again, the spiritual predisposing, precipitating, perpetuating factor can help you understand that person in front of you a lot, and then apply a plan to help them. And then keep in mind the religious change over time, like how the spirituality come about. It could actually start very strong, and then there could be, and then weaken over that. It really depends on the individual. Next slide, please. All right, don't hesitate to ask about like how the effect of the discrimination, Islamophobia has affected it, because it's considered cumulative trauma. It can contribute to what the meaning I indulge in that behavior or that substance. Explore like reasons of the struggle. Again, like you heard this from many sessions before me, they're all excellent in exploring this. I am having a weak faith, that's why I have this. This is a cognitive distortion. This is not true, and even from Islamic. You don't even have to ask an imam about it. This is not true. None of the Islam confirmed that, yes, that because this person is not connected, that means he will go into alcohol. That is not true. This is cognitive distortion. Just some facts. So enmeshed families are very, very, very normal in Muslim family, but it could be also source of stress. How the person views himself in the community is very essential. That's why the confidentiality is important. I can't see the last part, but I think it was something about, is it family history? I can't, it's cut off, Aziz.
Oh, it's authoritarian parenting.
Oh, authoritarian parenting. So it's very, very common that you will see, and like the father, for example, taking the role of authoritarian. It could be applied again. It could be normal, but it also, you could explore if there is a personal effect of it. Next slide, please. This is just a common example. There's a of the questions that you can ask. I actually heard much even better questions in the one before it, like how do you consider yourself as a religious person, or how does this how do you think Islam is playing your role in your life? All of this you can definitely take into account. I definitely see how is your relationship with God. I use this one, and I also use the connection. Is your connection with religious helpful, or is it distressful? I use this as an open-ended questions, and it tells you a lot of like who's the person in front of you. Next slide, please. All right. Okay. So there's nothing like again new into this. You can definitely go into the websites or the DSM and see how the diagnosis. I'm not going to dwell into a little bit. Easier something to say to remember is the 4C, loss of like the craving, loss of control, compulsion, or continued use. Next slide, please. Okay, so this is just explaining of how the difference between impulse control and the compulsive. The compulsive is we have an anxiety, we have a stress. I feel like a cage. I do this, I get a relief. Or the other one, and it might start with impulsive control where there is tension, I get a pleasure, and then it can progress into a compulsive disorder. Okay, next one, please. All right. This is more common characteristic of behavioral addictions. You can look into the source, and then and again, many online resources for this to diagnosis, like following the DSM-5 or following any criteria is easy to have it. The important thing is to take into consideration that individual, doing that individual assessment, and how the spirituality be incorporated. That's the key thing here. All right.
All right, inshallah, I'll take it from here, Dr. Hassan. Thank you so much. أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. الحمد لله رب العالمين. والصلاة والسلام على النبي الكريم. Assalamu alaikum, everyone. Thank you for being here, and thank you all for listening and so patiently. And Dr. Hassan, thank you so much. We had presentations earlier today, so I was not able to attend the earlier parts of the conference, but definitely seems like it's been a powerhouse. And Dr. Hassan and we were talking, and we were like, how do we cover all of this in 60 minutes? So we're like, we just got to run through it. So inshallah, my hope is that to add a few thoughts and enrich the discussion. It seems like there's been some really solid presentations going on. I'm going to start off really quickly. I'm going to make one note really quick on this one here in terms of the assessment and why I love this slide. It's usually, as I was trained, and usually, behavioral addiction or behavior start off as use, abuse, impulsive, compulsive, and then addiction. So it's very important when we assess people to know where they're at, because some people may be having this impulsivity towards a certain action. So they may have this, for example, whether it's eating, right? They get this impulse, they have the cravings that come, and then they just go and buy a burger, and then they're like, oh, like they take the first bite, or they make your pick. Whether I'm not I'm south of the border, so I apologize if I may use certain cultural nuances as incorrectly, it's because you guys are Canadians. And but like for example, Taco Bell is a common example. Oh, it's gonna taste so good. You take a bite and you're like, oh, that's so bad. Oh, why did I do this? Oh, So it's like that regret and self-reproach that comes in. If something becomes compulsive, compulsion is you don't want to and you're getting dragged into it over time. Where now it's more about the negative reinforcement that I'm feeling stressed about my exam, I'm feeling stressed about my work. And where it then becomes compulsive and addiction is that now it becomes more about I want to feel a little bit better out of my regular life, that I have this anxiety, this stress, and then I do my behavior and then I feel a little bit better, but then I feel terrible that I did this again, versus the pleasure part. That's what I just wanted to add that. Now, excuse me, I wanted to start off by giving a tale of two providers, and this is going to actually require all of you to be a bit more involved in the chat. Love to do some polls, but I don't know if you have the option for that, so I'm just going to run with this. So I'm going to give the tale of two providers and two stories. One is you have an imam, right? You have a religious authority, a religious leader. Couple comes to them. One shares about their addictive behavior. You can maybe think about it as eating. And they're like, oh, I eat a lot, I eat too much, I don't know what's going on. And they may start to do a little bit of counseling with them. And one of the things they may share is, this is a nafsi issue and you're supposed to eat less, sleep less, and talk less to other people and do these things. So almost like the other person might take that as like, I'm supposed to isolate myself. I'm supposed to, sleep less. I'm supposed to engage in worship and maybe wake up for, qiyam al-layl or like the night prayer. It's like, I need to be hard on myself. How many of you would, as clinicians, would agree with that intervention? That you're supposed to be more hard on yourself because you're overindulging. So now you need to get more control. How much of you would agree with it? Yes or no? And would think this imam is doing great therapy? No, I'm seeing some no's there. Yeah, okay. Yeah, and no, and we have a variety of reasons I would agree with the same, because, I think one of the things we normally see is a lot of lack of self-compassion. And we see that sometimes lack of self-care meaning what you do to care for yourself, good sleep, good hygiene. For sure, Zain, I agree. In some cases this works. But generally speaking, again, you want to assess more. And it's an imam. Generally speaking, our imams, because of lack of resources, unfortunately, aren't very well trained. And, we're doing better to provide them with those resources. Now, let me shift over to another provider. You have a mental health professional that a Muslim comes to and says, hey, I'm having, issues with like, marriage, and it's a female client, let's say a female clinician. And they say that, oh yeah, I'm having issues with my husband because, we're sexually a little incompatible. So it's a little difficult, but, I don't know what to do. And this clinician is very overt about like, what do you think is right? What do you feel like doing? And then the person's like, I'm practicing, I want to be mindful of his rights and the marriage. And then she's like, no, it's about what you want and what you feel comfortable with. I feel like you shouldn't be, you should basically say no. Whenever he says it, you should just say no, if you don't feel comfortable. And just, if it continues, I think you should, maybe it's not a bad idea to divorce him either. Or let's just take an example of a clinician, male or female, comes and they talk about masturbation and their shame about it from a religious context. And they say that, oh, like, this is bad. And they're like, how often do you do it? They're like, once a week. And the clinician's like, oh, that's very normal. This is healthy sexual behavior. It's okay. This happens, but let's talk about it. How many of you would consider these two examples to be good therapy? A little controversial, but kind of see what you guys think. Okay, I see a no from Kinza, no from Mawadda. Again, I don't know, I'm just saying, it's a quick example. Disagree, okay. Yeah, I would agree with all of you, not culturally or spiritually sensitive. Thank you, Jessica. That's the idea that many of us, it's not all wrong, exactly. Thank you, exactly, patience, values. And not even in a pluralistic environment, because I'm actually gonna jump in here as to see, for those of you who are clinicians, how comfortable are you with using or talking about spirituality in your sessions? And you don't have to answer in the chat. I want you to think about this. How comfortable are you with using and bringing out spirituality in the sessions? And secondly, how many of you are comfortable with or using or talking about religion? And whether that's even self-disclosure. Because, many of us as clinicians, we're people first and we are clinicians second. And as you guys all know, the classic transference, counter-transference is like, is our stuff coming into the session? Are we not wanting to talk about faith, even though that person just said that faith is very important to them? Are we holding it back, or are we holding back the sessions? And for those of you who may not be practicing, or let's say for clinicians who are not Muslim, how do we incorporate spirituality and religious when we are not even aware of what that is for the clinician, for the client, right? And we can learn about those things from the client, but sometimes we need this higher level understanding. We need a higher level appreciation for the client's values and their religious and spiritual traditions to be able to then very sensitively incorporate and integrate that into therapy, which is a whole process. The reason I bring this up, because I know we're short on time, is to give an appreciation that when we talk about spiritually integrated psychotherapy or integrating things, whether it's motivational interviewing, harm reduction, is that we need to first see how competent we feel about that. And even if we're not, can we get training? Can we talk to a religious scholar who is also trained in the behavioral sciences? Can we do consultation work? Because then we can be effective in terms of working with this client and utilizing interventions that they would be so much more receptive to, and their work would be so much faster. And I would say that is one of the core tenets of this conference, right? Is that how do we use these interventions and make them very effective? And this is where, we are, again, we need a system of, clergy and clinicians working together to create these spiritually integrated, therapies and interventions. But I'm just sharing this just as an appreciation, just for food for thought for now. Anyway, so one of these models is the traditional Islamically integrated psychotherapy. I just want to give this just for exposure purposes. This is something that we've created at Khalil Center. Like, for example, we talk about, when we talk about modern psychology, a lot of times it can be very Eurocentric, right? And that we have a historical, I know Dr. Rani had probably talked about it, our tradition with regards to mental health care and different conceptualizations of the self. So that there's aql, cognition, ruh, the spirit, ihsas, the emotions, nafs, the behavioral inclinations. So when we can use these terms with our clients who they may be actually talking about these, then we can also intervene with them, right? What is the intervention that we can do for these people? And then what is the outcome? And we talked about, again, Qalb Salim, which is from the narration of the Prophet ﷺ, that says that, there is a morsel of flesh in the body. If that is sound, everything is sound. If that is corrupt, everything else is corrupt. And that is the heart. All right. So again, this is just to show there are conceptualizations now out there. This is just one of them. There's more. I'll mention those later. But just to get an appreciation for it that can be utilized. Now, when we talk about change, right? How does change happen? Some of the questions to consider when we talk about addiction, especially because change is so, clients struggling with addiction, right? I'm not talking about like impulsive behavior or that they're using it sometimes. This is that the person is compelled to do these things, so really have to really tune into where they are. How motivated are they as an individual to change? What is the personal meaning behind this behavior? What does it give them? What pulls them to this? Because again, they may say, oh, it's wrong, right? Oh, it's bad. I shouldn't be doing this, whatever it is, because there's a lot of guilt and shame that goes into these things anyway. And then number 3, what is the level of impulse control? Are they able to direct themselves, or is this a generalized issue that it's, their impulses are uncontrolled or kind of off the rails, whether it's at work or with their family, or is it just happening in a very specific context? This is all good data for you, to evaluate where they're at and where are they in the stages of change. For those of you who don't know, Di Clemente, Francesca, stages, famous stages of change: pre-contemplation, contemplation, preparation, action, maintenance. I don't think there's needed to go detail into this. I think all of you probably know this. Pre-contemplation, person doesn't think there's a problem. Contemplation, yes, there's a problem, but I'm not sure if I want to change. Preparation, they've like, okay, what do I need to do to change? Action, I take those actions. And maintenance, how do I maintain it? So where do they fall in these? Because this is really going to help you when you go into motivational interviewing, to be able to give the client where they're at. So for example, a person's in therapy, and you can obviously see, you do an assessment, and they're talking about that they're eating out every day of the week, high fat, like high unhealthy fatty foods. And right after they say, yeah, I'm gonna go grab like a cheeseburger right now, because that's what I do after our sessions. It just makes me feel better. As a clinician, you might be like, But of course, as you say, you might say something like, hey, can we talk a little bit about this eating habit of yours? They may be like, yeah, it is kind of an issue. Or they may be like, I don't know what you're talking about. Because if they're like, if they're like, I don't know what I don't know what you're talking about, they're in pre-contemplation. But if they're in contemplation, then okay, that's where we intervene. And motivational interviewing, Steven Rolnick created this model where we collaborate with the client, we accept where they are, we also show compassion. But the main thing I feel like with motivation and avocation is avocation. It's the idea that we evoke the emotion. They may talk about like, yeah, I always feel terrible after I eat this. And then we evoke the emotion. This is a lot of emotion focused therapy. It's like, yeah, it's like almost like you feel like crap. You're like, yeah, I feel like I'm like the worst of this earth. And I'm just like, what am I doing with my life? So that evocation can help them create some level of change and take some level of action. So again, most of you know motivation review, but we're just going to go towards, this is again, a little bit of the process of the TIIP model, stages of change, process of change that we've developed as well, just to kind of give you, but you can read up on it. These are some of my recommendations, and I'll spend most of my time here, and then one more slide. Is the first step is, and this has been across the board today, talked about non-judgmental rapport building. Acceptance can lead to trust, that when they feel like we accept them, then there is that trust. And even with the behaviors, we'll need to evaluate our own ideas, whether, these could be people like, for example, there could be, a female clinician working with a male client who is going and sleeping and cheating on his wife. This could be a male clinician working with a female client who is burning off the money of the family and neglecting her kids. Could be any of those situations, but we just have to make sure that we are checking ourselves in this process, because again, people are able to detect it, right? Doesn't mean we don't have the right to our feelings, but we need to modulate that in the session, right? Number 2, spiritual shame and prevention. So shame, as Dr. Bernie Brown talks about, shame, guilt is, hey, I did something wrong, I did something bad. So, and then shame is, oh, I'm a bad person. Now, there's healthy shame, as talked about by many people in the past and clinicians in the 90s, 80s, 70s, like the shame that binds you in a bunch of other texts. There's shame, which indicates a feeling, an emotion. Like I wasn't able, when you fall down in the middle of the cafeteria and you spill milk on yourself, like that's shame that we feel like, ooh, like it's bad. But then there's what we call toxic shame, which is an identity. It's almost like there's like the me inside is hating the me, all of me. So I can't even run from my own criticism because I feel like I'm a piece of crap. So that's how they feel about these things, right? And in many of these situations, that's what there may be. And they may be projecting that same thing to Allah, to God. They may say, well, they say, and their knowledge, their religious knowledge will be used against them. This is how cunning addiction can be. For example, you may hear this, and I've heard this. People say, well, our teachers say that, a person is known by the deeds they do in private. And look at what I'm doing in private. I'm splurging my family's money. I'm going and doing this. I'm neglecting my children. Oh, I'm the worst of this world. Even though, Allah may not feel that way, and we don't know what God feels about us, but there's that hope, right? We'll talk about it. And this is where I want all of us to be mindful that we want to handle this with care. It may backfire if we're trying to hold their feet to the fire, or if we're trying to be a little too, oh, it's okay, I'm your friend, it happens, we want to be mindful, because if we go one or the other end, it may backfire. They may feel like, oh, there's no consequence to my actions, or there might be like, I'm the worst. Even my therapist hates me, and go into their shame and go into their spiral again. Which brings me to my next point, and this is the key here. The dance of hope and fear. And there's a big principle in our faith called Bain al-Khawfi wal-Raja, right? That between hope and fear. Like these are two, wings of the bird, and when we balance it, the bird is able to fly. Is that we want to be able to instill hope for our clients, but also to be able to fear, meaning accountability and addiction. We want to have compassionate accountability, where we want to compassionately accept that, hey, relapse is part of the process. At the same time, like, what made you want to go there? And asking the hard questions. So what happened? And how did that make you feel? And, like I remember with one client, one of the things I had to say, he was sleeping around, and I was like, so you're cheating on you're lying to your wife. It was hard. Like sometimes we have to say those things to like show, it's not like I hate you or I don't like you or I'm judging your behavior. I'm just stating a reality, because addiction is all about this perception and being in this bubble about that distorts one's reality. It's like, no, I'm just giving my wife a break. What? Bro, what? Again, that's where we need to give it to them a little bit, but not like in a harsh way. It's like, so you're cheating on her. It's like, oh. So that's really the balance. And I think good clinical skills here, coupled with good Islamic knowledge, can really help. Acceptance that part of them desires the object of escape. This is one of the hardest things with what some of my clients that I've worked with, is that they are so vehemently stuck on the idea that this is bad. I don't want any part in this. And like, oh, like it just showed up in my life randomly. I don't even know what happened. I just relapsed. Versus like, there is a part of them that desires this object. What does this object do for them? Why do they cling on to it? Really working through with them and really helping them understand that, which helps them get a little bit more motivation. And second to last, use of stories from spiritual traditions to reinforce the motivation and viewing stage, wherever they are at, right? There's hadith, there's numerous ahadith and prophetic sayings about, there was actually a companion of the Prophet who was, in modern day, we would call him an alcoholic, but he would love the alcohol, and the companions were chastising him. And Nabi Sallallahu Alaihi Wasallam, Prophet Muhammad, peace be upon him, he rebuked them and he said that don't do that to him. He loves Allah, Allah loves him. Meaning it's not a death sentence for the person, that we can give them hope and we can give them things that it's okay, bad, for example, a person's killed 100 people, yet Allah still forgave him. Again, there's hope in Allah's mercy, but also accountability. So balancing that out. Lastly, in this slide, training, consultations with people who consult with other clinicians who might be more aware of this stuff. Always a great idea. All right, moving forward. I know I don't have too much time. Decisional analysis is a great tool to have. Just Google it, find it. Resources, intervention, general treatment options. There's a biological approach to medications. There's anti-craving ones, and addiction. Please refer people to addiction medicine professionals for this. I think Dr. Hassan could be a great resource here for people in Canada. MashaAllah, he's teaching at the university level. He's very, very resourceful doing research and all of this. So please direct your questions to him for this, because we don't want just medications to be tossed around, especially with a neurobiological disease. It's a problem. So we need to be mindful of that. Maintenance program, meaning someone who's able to do, and I'll talk a little bit about it, treatment for comorbid mood, trauma responses, anxiety symptoms, and underlying psychiatric disorders, which you're most probably going to find. That's just the norm. Psychological approach, cognitive behavioral therapy, negative or positive reinforcement, reciprocal inhibition is a technique. Basically, you're replacing, for example, if they go out at 8 o'clock every night to go act out to whatever their behavior of choice is, then let's say they go to the mosque to attend a program. Then we replace it with something. In spiritual traditions, there's a principle where people are like almost like a vessel of water. When you empty the water out, the bad stuff, you have to replace it with the good stuff. Because if you don't, the bad stuff will show up again. Bad meaning, quote unquote, you get the point. Psychodynamic psychotherapy, motivational interviewing, being able to assess which comes from trauma, addiction, et cetera, et cetera. Psychosocial approaches, group therapy, 12-step groups. I'm a very big proponent of 12 steps. I often refer people to those. And then lastly, family therapy. Now, last slide, when we talk about spiritually congruent harm reduction, I have talked about these with scholars, with teachers. So I know that I'm not violating religious principles, right? And that's very important, I think, especially for your more practicing clients. But if you are a practicing clinician as well, I think it's important for us. It's like telling someone who is taking medication without consultation from a religious authority that, hey, like you're taking medication for your bipolar disorder, you don't have to fast. We as clinicians don't have the right to make that determination. I'm being very, I know, upfront about that. But that's where we need to collaborate with, scholars and imams and research articles that talk about these things. And there's a resurgence of this, with Dr. Rania talking about this earlier today as well, that there is more acceptability of this. There's a lot more conversations happening now, right? So when we do these kinds of things, if we're making it spiritually congruent, we want to make sure we are consulting with some religious authority or someone who knows a little bit more than us, or that we're not violating clear religious principles. This is, again, with clients who are practicing, because come to find out, the religious scholar may say, this, what are you doing? This is totally wrong, 110%. That may cause tension within the religious, within the therapeutic alliance, right? I know there's more conversations to be had about that. I'm just making a point. All right, general management plans. With behavioral addictions, from what I've read and understood, the goal is management. Abstinence may be an initial goal, but eventually it needs to be management, whether it's sex, whether it's food, whether it's relationships, whether it's the internet, gaming. Generally speaking, most of those things, there's a maintenance program that we need, right? So one of the plans that I use is a 3-circle plan. This is from the framework of Sex Addicts Anonymous. It's a 12-step fellowship. So the inner circle, and you can do this, right? Inner circle is whatever the behaviors that are that violate their sobriety, right? And when people list it out, it's pretty clear. And then the middle circle is their yellow light, which is if you're doing these things, you're kind of getting a little bit into your inner circle, you're kind of sliding down. So this is when you raise the flag, and raise the alarm bells, and like, oh my God, like we got to be careful. And the outer circle are the healthy things that you need to be doing in your life that maintain your sobriety. This is really good because when you do this with clients, they'll tell you, at least they tell me, yeah, I was really teetering between that inner and middle. I don't want to I knew it just somehow makes it very clear for them. Number 2, predictable versus compulsive. Now, harm reduction means they can engage in that behavior, but in a way that's less harmful. So for example, I work with pornography and sex addicts. So one of the things that commonly comes up is masturbation. Compulsivity is when the person is distressed, when they, let's say, have what we call affect dysregulation, when they're dysregulated, then they want to use an object of regulation to regulate themselves. That's what we want to try and avoid. We want to, let's say, make it predictable. For example, why don't you masturbate on Mondays and Fridays? And do it in a scheduled way. So it doesn't reinforce the cycle of I feel bad, I feel terrible. Oh, I should use that. It makes me feel better. I go use it. I feel better. I feel worse, etc. Versus this is part of your plan now. And then number 3 is gradual change. I mean, that's a principle within the prophetic tradition, especially when it came to the prohibition of alcohol. We want to be able to lower it. I mean, you could go cold turkey as well, but if we're going harm reduction, you want to go gradual change. If you're doing it 5 times a week, let's go 4, let's go 3, let's go 2. And the lesser of two evils, if someone's going to go, my examples tend to be sex addict oriented because that's my primary population. But whatever is the less problematic one. If someone's going to go burn all their money in Vegas, have them go get a local lotto ticket. The high may not be the best, but it's still something. Number 2, porn and sex addicts, masturbation without visuals is certainly an intervention that's, again, they predictably do it. Predictably, meaning they do it once or twice, and that may be the goal. That may be okay, well, if you just masturbate twice a week, predictively, proactively, that maybe you're not acting out on your, going to massage parlors or seeking escorts or cross-dressing or a bunch of other things that come up. And lastly, whatever you need to do. I know some of these things can get very, very, like eating excessively, binge purge. I mean, that's kind of crossing the line into eating disorders. you can do this with a safe person a little bit, and not go a little bit like have someone there with you. I know in methadone clinics and some other places, you always need to have a safe place and a safe person to be with when you might engage in some sort of your behavior. And again, behavioral addiction is such a big topic. It'll be hard to talk about each of them, but these are some general recommendations that I've come up with so far in my work. Lastly, Islamic integrated research, it's severely lacking at this time. I think where the stage we are at, in my limited understanding, is that there is certainly an appreciation for a need and a desire to do more. That people recognize spirituality and religious, values and culturally sensitive, appropriate therapy is important. However, the specific research to show which specific interventions work, that's still a work in progress. And that's why I think this conference is so important for this work as well, because all of us here, we're like the giants came before us, but now we are the ones who have to really apply these interventions and see what really works for our clients, so really we can make a significant contribution and make our interventions more effective with our clients. Here's some resources that Purify Your Gaze is an online website that works with Muslims and pornography. It's a self-paced program. I mean, that's just one thing that's available. There's research institutions like the Stanford Muslim Mental Health Lab, Khalil School of Islamic Psychology, the Cambridge Muslim College, Dr. Abdul, and all of them are doing some sort of research. Dr. Carrie L. York Karam is there, the Karam Institute. So there's a lot of these places and they have their models. We can certainly use those. Adapted 12-step would be a great idea as well. Few options are out there. There's some publications, but they're not very robust. Something that can match, the bigger institution at this time. And therapy with a culturally sensitive and religiously informed non-Muslim clinician. I've done this several times. I have some clients who've seen non-Muslim clients, and part of my CSAD, the sex addiction community, they sometimes talk to me like, hey, I have a Muslim client. What do I do about this, and this? So consultation is great. I think strong clinical skills have a lot of value coupled with consultation with others. And lastly, future areas of research, text covering Islamically integrated sex porn addiction for Muslim, text regarding treating and managing behavioral addictions in general, robust 12-step or group support network across the globe that's Islamically integrated. Because while 12-step in general is non-denominational, many Muslims shy away from it because they have reservations about something that doesn't come out from their tradition. So I think this would just make it, more accessible to people. With that, we'll wrap up here, and we'll open it up for questions. I apologize, that was like, but so much to share, so little time, but we'll pass here.
And Jazakallah. Thank you so much, Brother Abdul Aziz and Dr. Hassan, for the amazing information there on a very otherwise taboo topic in our community. And by the way, I have to give some extra credit. I think the MMAC should probably do awards for people like Abdul Aziz who go and specialize in areas like becoming a sex addiction therapist. Most Muslims will run at the word sex anywhere. So for someone to go and actually specialize and become a sex addict, a sex addict therapist, and specialize in that type of therapy, I think that's definitely needs to be encouraged in our community. Inshallah. So mashallah, good for you for doing that. So we have a few questions here, and if there's anyone else in the audience who'd like to put their questions through, please feel free to use the question and answer section. So the first question, and we'll try to make the answers both Dr. Hassan and Abdul Aziz, if you guys can try to make the answers as broad as possible to help as many of the audience members with their different issues. The first question is actually, it's more specific. It's asking if the Canadian Association for Mental Health caters for a religious, spiritual context of Muslim patients with addictions. So maybe Dr. Hassan, if you want to just quickly comment, if you know anything about CAMH and if they have any spiritual direction in terms of their therapy.
Okay, well, I think, there's a lot of emphasis on using the multicultural standard and cultural assessment. I think where the way it stands right now, that there is like the services are still divided by the problems. Basically, addiction has its own divisions, mood anxiety has its own division, refugee has its own division, where everybody has a different, but there is an awareness of who does what. Like, for example, in addictions, like if there is a person who wants to have a specific Muslims treater or a clinician, then they know where to go to. So general advice, no general, like a generic name. They really wanted to be open, but my things that my biggest, like the thing that I want to really emphasize is you want to be assertive. If you really want a person, like a Muslim clinician, you feel this is who you can relate to, then you can just ask. And they will able to guide you. It's like a map, and then you ask, so then you get it divided. Is it possible to get this? Is it possible to get a Muslim practitioner? And then things will branch out. So follow the general systematic approach, but be assertive of what your actual individual needs.
Thank you so much. And I think back to Abdul Aziz's last slide is that this area, having Muslim mental health professionals being able to address these kind of things, it's very underrepresented still. So, you know, most places it's going to be about who you know and knowing a specific mental health professional that can help you with that, rather than, you know, expecting there to be, you know, a banner saying, you know, this program at CAMH is to help Muslims with this very specific problem. It's probably going to be very difficult to find. Rather, I think for now, until you know, that's available, you know, it's great to have pioneers like Khalil Center, or even outside of Khalil Center, to have other Muslim health professionals that we can recognize. And the MMAC has a great resource with a list of all the different Muslim mental health providers who specialize in different areas, different geographic areas, different disciplines. So that would probably be a good resource to look into. So we'll go on to the next question. So we have a question saying, what are some strategies to help? So if you are a Muslim mental health professional, what are some strategies that you can use to help your patient who's a Muslim to open up about an issue that they might consider sinful, you know, other than suicide, so things like addiction or things like that? Any strategies there for people? And then it says, I find occasionally there's hesitancy and the faith concordance actually becomes a barrier. So I guess maybe this question is both ways. Maybe sometimes you want to solicit the patient to be comfortable with sharing things that are taboo in our religion, and other times you want to eliminate that as a barrier, maybe if they recognize you as a Muslim mental health professional.
You know, it's funny because you know, people come to me for this issue, so I'm just like, when was the last time I had to make someone open up about this? But I guess I think one thing would be to advertise it. If you do work with this and talk about it in a very compassionate way, whether it's whatever the sin is, alcohol, you know, drugs, pornography, whatever it may be. Number two, this is something, especially for the more practicing Muslims, they feel like they're trying to, like, they're disclosing their sins. And they have this principle, like, we shouldn't disclose our sins. And versus, you know, there's a lot of, you know, Imam Ghazali talks about it in his Ihya as well. If this is for very specific treatment and this is for your betterment, then you need to be honest and open about it. But being able to address that from, again, don't just, you're like, well, in the tradition, you know, it kind of says, give them evidences. Sometimes they need that. And number three, I think, like, for example, like a female client may have a very hard time with sharing her, if she has like hypersexual behavior, with a male clinician. I mean, we have to be mindful of that. It's not always the case, but it may be that maybe the client therapist relationship, there's some barriers. And if you see that, and you can always assess for it too, by the way, this is really good. You can always like ask in the beginning, if they have impulse control, you can just ask like, okay, well, do you use pornography? How often do you masturbate? Now, again, you want to be mindful of that as well with the religious context. If it's a male doing with a male, it's kind of easier. Female doing with a female, it's a lot easier. But if it's the other way around, it can get a little dicey. So just prepare for it. If you do it well, I think they can find it better. At the end of the day, too, you know, we have to put the onus on the clients as well. You know, the hope is that when they reach a certain point, that they will share. Our job is to make sure that we have the environment where they can feel comfortable or feel the necessity to share.
Absolutely. And I can also just add as well, like from my practice, being in general practice, I come across all kinds of different people. Sometimes they're Muslim, clearly they can identify. Sometimes they don't know I'm Muslim. And so a lot of times it's just about with any, and to be honest with you, like living in North America, it's not only like even if you find someone who's not Muslim, but a lot of the same principles apply. That people might feel judged for other reasons. And like and sometimes I'll come in and I'll identify and even though I can tell maybe they're Muslim from their name, I'll specifically won't say salam to them. And then I find later on, I'm like, oh, you know what? I made a good decision because, for example, maybe this person has a Muslim name, doesn't identify really with being Muslim, might be from an LGBTQ or other community where they would have feel judged, and they're here to actually get their medication to prevent HIV/AIDS, which they would use, to allow them to freely, practice certain types of intercourse and stuff like that, right? So it's a very I think it's really about setting the stage and knowing when to divulge certain things, and just like with other STIs, STDs, we have to always tell them, look, everything, certain things are confidential, certain things, if you're positive for HIV, for example, I do have to report it. So I think same thing with in our faith, sharing it when we feel it's relevant, and setting that atmosphere. And then if you don't feel the connection is there, sometimes, for example, if it is a female, I'd offer them, if you prefer, I can recommend you to a female physician or a female practitioner, or vice versa, so that if you're a female, let's say, you can offer a male person. But I think just setting that stage and setting the tone, I found is very helpful for me. So I think that's good for that question. If that's okay, we'll move on to the next one. So how do you best counsel someone who is harsh on themselves and doesn't have much self-compassion, as is often the case with patients who have OCD as well as addiction? So what are some strategies to build that compassion for people who don't have it for themselves? Dr. Hassan, Abdul Aziz, any strategies?
Dr. Hassan, I have some thoughts, but I want to give you a chance to travel. Oh, okay. OCD is OCD is a very, very difficult thing. I think, especially I think we deal with a lot of the scrupulosity, the religious-based OCD around wudu and tahara and washing and, bathing and urine and a bunch of other things. Honestly, what I've found helpful, and this is to keep it broad, is really I work from a narrative lens, and to see what the story has been, what gets to this point. I use like a storybook example. If you open page, 120 of Harry Potter, and you're seeing like he's soaring on this little, firebolt, and the dragon's behind him. You're like, what happened? How did he get here? You have to go back to the story from the beginning. Number two, I think if they see some progress, it's good. And number three, groups is really good. I would say if you can put them in a group of people who are similar, because a lot of times, especially for our community, it's very insular. We don't share a lot of these things with other people. If you're able to put them in a group together with other people, especially addiction. I can't speak for the OCD, but it's very similar. Addiction, I know, putting them in a group and having just sharing their story, and other people are like, we love and care about you, man. Like this is tough. And then they're like, just like, never thought anyone could accept me. So sometimes, we need to be loved in order to love ourselves, and vice versa could work too. But these are some brief thoughts.
That's good. Yeah.
Okay, well said. Like I think Aziz have really summarized it. But in general, I'll tell you like my rule. Like there's something about medicine in general lately has been about customized medicine, right? And the customized individual. We try now to get your your blood, to able to know which medication will work for that. This is the same thing apply, and this is actually applied to the previous question, and it might apply also for future question. Again, like remember my point I mentioned, that I do not assume universality. Like Dr. Suleiman mentions beautifully, you go slow. You have to assess the individual. I usually have the feeling within the first 15 minutes, like how much of this is spirituality. If you're still not sure, you can still ask. And then this is what would determine how to best counsel. Like if you want to really incorporate spirituality or not. If not, the spirituality is not, then you're going to use the generic term of the cognitive behavior therapy. How would you see this? What are the positive? into this? How would others? What would you tell your friends? So this is cinema in general. You put them into group, yes, and they can hear other ways. And then you want to use the spirituality. To be honest, like I'll tell you, me personally, once I know that person isn't really engaged in spirituality, I kind of it brings me joy because it's my field of expertise and I can put a lot into it. You can really easily incorporate. But again, even that level of spirituality would really difference from one to another. You can use a lot of beautiful things. The last session, I think that presenter, mashallah, has talked about spiritual spins and how Allah the most merciful and His mercy is only one to this universe, where the other it's 100 mercy, the others is still to come. So you can use this part as a, for the individual. Again, you will have to set that level according to that individual in front of you, and that occur by the assessment. First, you inquire. You just have to say, well, how does you can try, give it a try. If that individual seems to be put a wall, then you set back and then you try different route. It will really, there is no, I wish like I can tell you one answer that can really fit, but it really, you have to be open to all different connections. You have different tool in your toolbox, and then you apply it accordingly, according to that need. That's my
actually, one other point I just wanted to emphasize also, the really nice thing I found about groups also is that because sometimes the therapists themselves might not have experience with OCD, for example, or whatever the actual issue is at heart, like another type of addiction, but having someone else in the group who actually experiences that, be able to offer their own personal advice is sometimes even more powerful than seeing a therapist for that issue, right? So someone might in this group disclose that they have no compassion for themselves, and then there might be 2 or 3 other people in the group who already have overcome that and can speak to that from their own personal experience. So a lot of the times when I've been present in groups, I'm actually learning more as a therapist than than I'm actually sharing, right? It's really, I find it's the same job I'm doing here. I'm just like a moderator, I'm just sitting here learning from other people. I find it's the same with groups. So that's another good, powerful advantage there. The next questions, I'm just going to do a quick 2-in-1, and these are both, I think, going to be directed to Dr. Ahmed Hassan. The first question is, do we know the prevalence of addictions in Muslim Canadians? How common is it, and what are the demographics most affected? And are there specific substance behaviors that are most prevalent in Muslims? So that's question number 1. Question number 2 is, have you found addiction? The other one was, is there any anti-craving medication for behavioral addictions? I can quickly just share the few that I know. So, for example, for medications, I know there are a lot of medications available. Like, for example, for eating disorder, for example, there's medications like Contrave. There's Vyvanse as well that's indicated for binge eating. So those are 2 off the top of my head. I know there's things like naloxone and naltrexone that's used similar to Contrave can be used for smoking addictions and other types of addictions. So I'll just start with that quickly, and then I'll leave it to you, Dr. Hassan, if you can share if there's any other anti-craving medications for behavioral addictions you're aware of, and also if you can speak to the prevalence of mental health, of addiction specifically in Muslim Canadians.
Sure. So in general, I won't call it anti-craving medication. I really just call it medications for behavior, because when you talk about anti-craving, there's a lot of anti-craving for alcohol. There's a lot of anti-craving, or if you want to call it opioid agonist treatment for opioid. When it comes to behavior, for example, yes, Dr. Sama, you're absolutely right. So for example, there's good evidence that naltrexone will be good use for gambling disorder, for example. It's just to block the opioid receptor and might the blood craving. There's a lot of interest of using it also for others way. Again, when do you use this or not? So remember the question that Abdul Aziz has mentioned, what is the impulses of that person? So this is what usually I determine if that person needs it or not. So it will need to be an assessment. But the short answer, yes, there's some medication, not very well studies or approved for this, but it actually can work in some cases. With a proper assessment, we can identify the needs for it. Remember, there's also, like, if the root is something else, like depression and anxiety, there might be a helpful medication to help with the root, to help you go through lesser through the treatment process. The prevalence, the prevalence is really very few research into this area. Very scarce. I can't speak that because from a public health perspective, it's not really a national representative. We have a study that's really under preparation right now from This is the closest one. We get it from 2013 from the US national public into the general. It really follows the same general prevalence, which is alcohol is one of the most one, followed by the others, cannabis, but in a way much less prevalence than that than the general public, which is why again maybe the spiritual piece. However, the prevalence of smoking, specifically the smoking and the nicotine, are very much equal to the general public. This is very common, and I've actually looked into the prevalence of smoking even in the Muslim countries. It's way increases. It goes up to 35% in some male countries like Saudi Arabia, where I'm from. So it's really high. And this is again guided of what I was saying earlier, the spiritual way, how guided, because how this categorized as haram is very different than how the khamr is, or alcohol is categorized as haram, is very different than this. So it guides again the culture, which guide again what people makes acceptable or not. So yeah.
That's great. So since you brought up the substance, there's a question here. What's the best approach for a client who shows up under the influence of a substance to an actual therapeutic session? So for example, someone who shows up drunk or high from cannabis or something like that.
Well, again, so it will depends on if that person. So the best approach for a client to show up where? Show up into the clinical session? Okay, so in general, like if the patient is showing up in a group, we don't really encourage that because it can influence. And I think most, if not all of the group session have this as a prohibition. If that, then you will ask, if you're doing it virtually, there's a beautiful thing of like moving the patient to the lobby, and then you talk to them about the reasons, and then you debrief after when they sober up to clarify, and then invite them again. Never try to say it's like you kicked out. If you're an actual like in-person group, we do the same thing. If you notice something, you ask the patient to come outside. Usually it's conducted by two therapists. One will continue the therapy and the other one will talk to the guy that is maybe is not approached, and then you ask for a follow-up session and you talk up. If the patient show up in the assessment, you have the choice. Like I sometimes, yes, I know that I can smell some alcohol, and I decide to go because I know that they will always show up, because if they stop, I can actually go into seizures or withdrawal. So I have to decide. But if the patient is too intoxicated to the point that he cannot apprehend what I'm saying, then I'll have to do an alternative. So you really, again, you'll have to determine of what is the situation and how much intoxication is available. But hopefully this gives you the best common scenarios and how you can address it.
Perfect. Thank you so much. So we'll finish with one last question, and then we only have two questions left, so we'll just have to wrap it up because it's almost 5 o'clock. So the last question we'll answer, and then the because it's anonymous, and then the final question we'll see if we can send that person a private message to answer that question. So specifically, there's someone asking about for people with pornography addiction and other hypersexual behaviors, but they have a concurrent schizophrenia diagnosis. The person who's asking the question says the challenge is that they have very limited insight into their behavior because of the schizophrenia and very little impulse control. And any thoughts or suggestions on how to deal with a situation like that?
Yeah, again, this is an excellent question, and it's pretty common when it comes with comorbid with other psychiatry disorders, such as like schizophrenia, which is one of the very major psychiatric illnesses. You really have to assess how much, the lack of insight. It could be, there could be a lot of reasons, and it's really all of them common. It could be that behavior is guided by voices. So that's completely something else. That by voices that's telling them that this has to do with good morality or doing something good, or this is the right path. So that means obviously this is what we call delusion. So the treatment really has to be by like an antipsychotic or the treatment of the psychosis, and able to even talk about this. Otherwise, the person will be under the delusion that this is the right thing. But it could be that doesn't mean necessarily any person with a psychotic disorder that this is doing out of delusion. It could be completely well controlled under the medication, which is in a lot of cases. But again, they will fall under the general problem as if there is no comorbidity, which is This is a way of rewarding. This is a way of relieving some stress. And then you gotta just follow the general approach that we talked about, like even Abdul Aziz has talked about this. So it will really depend on what's the meaning of why is this is happening. It happens through an assessment, and we have to know, is it a medical? By that I mean it really influenced by the delusion, or no, it's completely something else, and this is something that become a habitual, or if you want to call it an addiction.
All right. Jazakallah, thank you so much for everything. I'll get a virtual round of applause for our speakers for answering all the questions and giving us such great insight.